Thank you so much, Dr. Palumbo. Thank you for the kind invitation. This is a wonderful course. I'm very honored to be here today. Even though I'm from the United States currently, I'm actually Italian in origin. So the accent that you hear is Italian. And, and so I will go on with this. I have no disclosures. And these are the learning objectives for this talk. So we will try to understand the embryologic processes that cause uterine malformations, critically appraise 2D and 3D ultrasound for diagnosing Müllerian anomalies, and then we will appraise the few Müllerian anomalies that are actually important for obstetrics, and we will review the ESHRE, ESGE, and the MAC 2021 classifications for Müllerian anomalies. And so we will continue on. So the first I wanted to review with you how the Müllerian structures are formed in the embryo. What is astonishing is that everything is already completed by the end of the first trimester, basically. So the uterus, the tubes are already present, and so if you want to follow the structures on the, in blue on the right-hand side, you can see, actually on the left, you can see how the Müllerian ducts are completely separate in the very beginning of life, and then they fuse together to form the body of the uterus and the upper 2/3 of the vagina. And also, of course, the tubes. The ovaries have a different embryological origin, and so they're completely separate. So whenever I speak with my fellows and the residents, I always have to point out that the ovaries are completely different. So the presence or absence of the ovaries are not connected, and they're not part of the Müllerian anomalies. So going on after this, as you can see, the fusion happens very early on, and then there is the reabsorption of the inner septum of the two tubes that basically fuse together. And so keep that in mind, because there's different defects, and this is the classification from the 2021 MAC 2021. And in this case, you can see how these defects of fusion and the reabsorption of the inner septum actually can explain all these Müllerian anomalies. We will go into more details later, so you don't have to memorize anything here, and we don't really need to go through them. And I first wanted to show you what is the complete uterine agenesis, which is also called the Mayer-Rokitansky-Kuster-Hauser syndrome. And which is the complete absence of the uterus and the tubes, and typically there is no vagina as well, and so there's no bulging at the level of the hymen ever whenever we see this uterine agenesis. And then I wanted to introduce to you a case that presented to me a few years back, quite a few years back. And this was a 17-year-old female with a history of cyclic pelvic pain and an MRI diagnosis of imperforate hymen. Please note the MRI diagnosis of imperforate hymen. So when she came to me, she came mostly for this imperforate hymen. And so I did an ultrasound on her, and at that time we did it transabdominal, and you can see the very poor quality of these images. But I did measure a uterus that was pretty decent size. It was a little smaller, but it was okay. And then I could see the bladder, the uterus that was retroverted, and so on ultrasound, on transabdominal ultrasound at that time, I said, okay, this is most likely what the MRI showed, which is an imperforate hymen. And so when I instead went to do her laparoscopy, I found a completely different picture. And so I could see that there were two different hemiuteri, that there was no central body of the uterus. The ovaries were extrapelvic. They were in the upper part of the abdomen above the pelvic brim. And she also had something that I did not depict here, but those were hydrosalpinges. But there was, of course, no hematocolpus because there was no vagina. And so I went back to looking at those images, and I was thinking, well, what did I see then when I did my ultrasound, right? I couldn't understand. And so what I thought was the bladder was actually a right hematosalpinx. And what I was seeing was only the right side, so the right hemiuterus on the right. And in the dark, when I did my transabdominal ultrasound, I didn't realize that my hand had shifted towards the patient's right in order to find the uterus, and I just couldn't understand that was only half of the uterus and not the whole thing. So I was mesmerized by this, but it taught me a lot, and it taught me to be very humble whenever we see a Mullerian anomaly or a suspected Mullerian anomaly, because what we see might not be what we find in the end. So there was no imperforate hymen. There was actually no vagina there. And so the management for her was to use vaginal dilators to create a new vagina, and then continuous OCPs, or oral contraceptives, I'm sorry for the acronym, to treat this hydrosalpinx that was forming every month and was giving her that cyclic pain. So what I learned also at that time was that there's only a few of the Mullerian anomalies that are really important for obstetrics, which are the ones that we treat every day. So I'm a reproductive endocrinologist in the United States, and I am a surgeon and an ultrasonographer at the same time. And so I made it part of my career trying to understand what was really important that we were looking at. And so the unicorniate uterus, bicorniate, didelphus, and septate uteri are the ones that are important to us as adult reproductive endocrinologists or general gynecologists. But for all the other Mullerian anomalies are important for the pediatric adolescent gynecologists that see these young patients, like the 17-year-old with cyclic pain and with other structures, abnormalities that prevent even them from becoming pregnant. So these are the four that we will focus on today, and these are depicted here by Dr. Pfeiffer in the MAC 2021 classification, and I'm actually part of that task force for the MAC 2021, so I'm a little biased possibly in presenting you all these pictures from the American classification and not the ESHRE, but we will touch on the ESHRE as well. So what is the impact on fertility and pregnancy of these conditions? Well, the unicorniate, bicorniate, and didelphus uteri can cause a preterm delivery, malpresentation, because the baby cannot turn effectively if it decides to turn after the first trimester. And there is an increased cesarean section rate. However, they do not need basically any intervention on our side, because the patients can conceive, and unless there is a septum that complicates the bicorniate uterus or a didelphus uterus, of course, then we don't need to really intervene surgically on them. As opposed to the septate, subseptate, and the arcuate uterus, which the last two, the subseptate and arcuate uterus, do not really exist anymore based on the new classifications, and so we will touch upon them as well. But they can decrease pregnancy and live birth rates, both in IVF and also in the spontaneous pregnancies. And we know that the restoration of normal fertility and pregnancy can be achieved with surgical correction. So the uterine septum is something that I studied a lot in my career, and trying to find what would be the perfect cutoff. And so I'm a little critical on that on all classifications, and you will see it. So the diagnosis of unicornuate uterus, as you saw Dr. Palumbo before and all the other speakers, the 3D is really instrumental in diagnosing the unicornuate uterus. And that's what I use every day in my practice as well. It's not very common. However, you might encounter it in your career. And again, I'm a surgeon, so I always look at the quality assurance of whenever I do a laparoscopy or a hysteroscopy with all these uterine malformations. So it's very easy to diagnose with 3D. And I think, again, 3D has revolutionized the way that we really diagnose these malformations, that when I was a resident and a fellow were actually very mysterious because you didn't have 3D, and so it was very difficult to diagnose them. The bicornuate uterus, based on this MAC 2021 classification, you need to have an indentation of the outer contour that is greater than 10 millimeters in order to diagnose a bicornuate uterus. And you can see it here how we typically diagnose it. So on your coronal view of the 3D of the uterus, you just trace this line that connects the top of the outer contour, and then I go straight in the middle and I measure that indentation inside that outer contour. If you see, bicornuate uterus also can have subseptations, like in this case you can see a septum, and whenever you have a septum in bicornuate uteri, you want to incise the septum only without touching the outer contour or the inner contour. So you just have to be very careful whenever you resect that septum. And again, surgery is our quality assurance to make sure that we perform the diagnosis correctly. However, there's very little to add to the 3D ultrasound diagnosis, as you can see. The didelphys uterus, it was a very I don't know, but surrealistic diagnosis to me, because I'm like, yes, you have a didelphys only if you have a complete separate uteri and vagina and the two cervices. But in reality, the diagnosis of didelphys uterus is much more common than I thought, because you actually diagnose a didelphys even when you have the two cervices that are together, as long as your separation of the uterine horns is below your internal os. So that's the new definition, or I would say I possibly adopted it late, but that's the definition of didelphys uterus. So you don't need to have the two separate cervices. Many times they're attached together, but as long as you have the connection below the internal os, that's your diagnosis there. Although during a hysterosalpingogram, you can see how the two uterine horns and cervices are completely separate. And on ultrasound, it's sometimes difficult to appreciate the cervices and how separate they might be. With the 3D, though, you can really measure the this internal os and where the line stands, and so you can make your diagnosis of didelphys uterus. So after I adopted that concept, which is actually adopted by the MAC 2021 classification, it will be much more frequent to see this didelphys uterus, which is nothing else than a bicornuate uterus in our hand sometimes. And so in this case, what you see is a vaginal septum, because didelphys uteri many times have vaginal septi or even completely separate the vagina. And you can see the two external ostia of the two cervices that are still attached. But in this case, again, this is not a septum. These are two separate cervices. So the uterine septum, we will spend possibly a little longer on this, but we adopted the 10 millimeter rule a long time ago. It was actually in the early 90s when Dr. Salim from Egypt adopted an old definition or hysteroscopic definition by Dr. Fedele, who was in Italy instead. And basically, Dr. Salim adapted the 3D ultrasound view of the uterine septum, and he was one of the first ones. So that's a great merit that he has. And he said, okay, Dr. Fedele said that if you have a 10 millimeter remnant of a septum that you have resected, that's still important for obstetric outcomes, and so you should possibly incise the septum if it is more than 10 millimeters. So what he did was to measure this 10 millimeter septum on 3D, and he said, okay, so if you have this length on 3D, you have to resect it, and if you don't instead, then it's an arcuate uterus, you don't have to do anything. And that was adopted, well, it was valid for a very long time, up until the ASHRAE classification came, and then the ASRM classification in 2011, actually, when they defined the septum in a different way. So the ASRM classification at that point was just saying, well, if you have a septum more than 15 millimeters, then you should incise it. But if it is 10 or less, it's considered an arcuate, and so you don't incise it. And whatever is in between, well, that is a gray zone. So if the patient has a history, then you're allowed to incise it, but if not, you really don't have to do anything, and you just leave it in there. All these, and the ASHRAE said was instead considering the 50% of the fundal thickness, which also was revised a couple of times. But none of these investigators really was taking in mind what was the patient, what was the patient's symptomatology or anything else. So I became a little critical of that, and I also did some other studies which I will not depict for you here today. But just keep in mind, you just don't want to take everything that the classifications sometimes give you. So for the uterine septum, though, despite all these dissenting ideas about what should be the length that you should incise it, well, we know that the combined hysteroscopy and laparoscopy was the gold standard for diagnosing it, as you also saw Dr. Palumbo saying that before. And with imaging, we have different options. So we have MRI, hysterosalpingography, 3D ultrasound. I still find in the US at least, that they use hysterosalpingography to diagnose the septum, and I just grinch at them. But if you see, the hysterosalpingography indeed is very useful if you have a normal cavity. As it is the 3D ultrasound, as it is the MRI, right? So the three are comparable whenever we have a normal cavity. But when we have a septum instead, the HSG cannot give you any differentiations between a bicornate uterus or a septate uterus. Yes, it tells you, oh, there is something there, but it cannot give you a real diagnosis. The MRI is extremely useful, and it was considered the gold standard for imaging of the uterine septum up until a few years ago. However, the MRI has some caveats that we need to know. For instance, if you don't have the uterus, that is those aligned with the 45-degree angle of the MRI evaluation, you will not be able to see the internal and the external contour of the uterine cavity at the same time. And so most of the times the MRI will not give you a good diagnosis, and in the specifics it will not also be able to measure the septum accurately. So it's only with the 3D ultrasound, where you've seen all the manipulations that our GE experts showed you before, that you can rotate your image back and forth multiple times until you find that perfect image. The outer contour is there, the inner contour is there, you can see it down to the internal os, and that's when you can make your diagnosis and you can measure it accurately. So in the last few years, it's actually 3D ultrasound, the gold standard to diagnose a uterine septum. So I promised you to touch upon the ASHRAE-ESGE classification. So it came out in 2013, and they were basically diagnosing the bicornate uterus and the uterine septum more or less in the same way. So they were measured as an internal indentation. It was more than 50% of the total thickness of the fundus. But then they came back saying, oh, but then if you have a fibroid, that's not so accurate anymore. Oh, and if you have adenomyosis, that's not accurate so much anymore. So in 2014, they came out saying, well, maybe when you have this kind of, and I don't know if there's anybody from that classification task force, but so in 2014 they came back saying, oh, well, maybe you can just use the anteroposterior diameter, you use an average, and then you calculate your 50% based on that. A little cumbersome to do, right, on the daily practice. And so in 2016, they came back and went back to the original classification. So it should be only the fundus, and then you can use the anteroposterior only if, in your opinion, the fundus is not the best place to actually measure your thickness of your wall. So a little bit of disagreement within that classification, and that's why, at least in the United States, it's not really used because it's so cumbersome. Here is an example of what you would consider a septum if you use the classification from ASHRAE-ESGE. And what you can see here to the far left, this is a subseptation that was measured about 6 millimeters, but with a total thickness of 11 millimeters. So this was technically a septum, even though it was just a 6 millimeter arch that was coming down inside the cavity. And then instead, the other two examples, the one in the middle and the one to the far right, those are definitely nailed by that classification. But what is the impact of the septum on dysmenorrhea and also on pregnancy, right? Because we don't really know what happens. But what we think that happens is that it's a combination of the distortion of the cavity and the abnormal vascularity. So what I attempted to explain was that if the pregnancy implants at the level of the septum, then it's much easier to have a miscarriage out of that, just because there is where at the level of the septum we don't have the spiral arteries that grow inside the endometrium, and so the placentation of that pregnancy is not optimal, and that's why typically the pregnancies from septi have in a miscarriage or early loss, typically around 7 or 8 weeks gestation, which is when the placenta really becomes much more prominent. And then also for dysmenorrhea, which is a very underrated symptom of these subseptations, that is basically the contraction of the uterus and the cramping that happens during menstruation that causes the excessive pain for these patients. But they don't know. Remember, they were born with a septum. So since the first menses, they just don't know what is supposed to feel. And so they will never volunteer that they have some pain. Right? They will, unless you really ask them if they have pain, if it is, you just have to characterize it a little bit. So when to intervene? We're going back to that question from before. Well, if you see here, whenever we intervene hysteroscopically, we perform an incision of the septum. So we don't take any specimen with us, because we typically do it with scissors, or even if we use a resectoscope, we typically use it as a blade. So I normally flatten that loop that I use for myomectomies. I flatten it down, and then I use it as a knife, and I just go from side to side, especially in the very long septi that tend to bleed a little more and I cannot see hysteroscopically. I use the resectoscope in that way, but I never take a specimen because it's only the apposition of the anterior and the posterior wall that I'm addressing, and so I'm just dividing the septum in between, and I go right in the middle, and I just go all the way up to the fundus, keeping the tubal ostia always inside. So if you're with me doing a hysteroscopy for a septum, you might become seasick because because of the uterus being very wide, I constantly come back and forth looking for the ostia to make sure that I'm at the right level, especially when I start touching the fundus of the uterus. So I don't know if you've ever seen the images of a uterus before and after a septum. This was a case that presented to me a long time ago. It was 2013. And so this was a complete septum with a vaginal septum, but if you look at the outer contour is completely flat, so that meant that it was a septum. So I went in and did my surgery, and then approximately a month afterwards I had the patient come back for another ultrasound to see if I had indeed incised the whole septum. And I did. I had done a fairly good job, but what surprised me was the width of that uterus. So if you look at the width of the uterus here, it was about 7 centimeters. But then after surgery, this was a completely normal uterus with a 4.5 centimeter width. And so that again taught me how the uterus can recoil and regain its shape as soon as you just detach the anterior from the posterior wall that holds the whole uterus down and the cavity much wider. So in conclusion, the MAC 2021 classification tries to reconcile imaging with the clinical diagnosis of uterine malformation because they went back to the 10 millimeter rule that we've been adopting since Dr. Fedele's publications in the 80s, actually. And then the unicorniate, bicorniate, and didelphous uterus have a small impact on fertility outcomes and do not really need intervention unless they're complicated by a septum. The uterine septum has implications on fertility and on adverse pregnancy outcomes, and it should be incised when greater than 10 millimeters, according to the latest classification in the United States. Yet we know that many miscarriages occur with septi much less than 10 millimeters in length, and so it's very difficult to find that real measurement that should advise when to incise the septum. Dysmenorrhea is an underestimated symptom of uterine subseptations less than 10 millimeter length and should be considered an indication for surgery, especially in these young patients that present to you in their early 20s and they have dysmenorrhea and you find the septum. Well, I never wait for them to have their first pregnancy loss before I incise that septum, but I go ahead and address it as soon as I can. So with that, I thank you so much for your attention. I'm sorry if it was a little longer. Thank you so much.